All right, thank you everybody for joining us this morning. We really appreciate you taking time out of your schedules. Very excited to have Dr. Curry Leavitt kick us off for the first of 2 corporate forums. And we're running behind schedule, so I'll let him take it from here.
All right, welcome everybody. Sorry for the delay. I know that with AV, with any type of meeting, could be a little frustrating, but I'm not going to stand on the stage. I'm going to roam around. I know that's kind of how I like to do things. Anyway, I'd like to thank BioXclude, Snoasis, and we're going to present a lot on BioXclude today, talking about placental membranes, amnion-chorion membranes. And to get into it, I grew up in Las Vegas. You saw this slide earlier. Growing up in Vegas, you get a lot of misconceptions about how that living is. But more so, I look at the strip, here, and what really sets the Paris aside from Aria? What makes the Cosmo maybe a little bit, more appealing than the MGM, across the street? Literally, look how congested this is. I even look at it and I parallel this even to my practice, to where I have a periodontist across the street, I have an oral surgeon down the street. Literally, competition within my practice quite a bit. And so, looking at marketing and looking at the way you do things, what are you going to do that's maybe going to do things a little bit differently in your practice to be successful? And so, whether how you treat your team or the materials that you use within your practice, what are you going to do to make yourselves different? And there's a lot of new technology and especially new biomaterials that we have at our disposal that we're going to talk about today. And so, looking at this is our BioXclude membrane. Everything is labeled here with a little smiley face. It's a barrier and a carrier all in one product. When I say that, is that we've got an occlusion aspect to a membrane is what we want, but it also is a carrier with a number of very, very important materials and growth factors that will enhance our growing here, okay, within our grafting materials. And so we're not going to get into this very much, but you can see the biology between what we have here with our amnion-chorion membranes, an epithelial layer, a basement membrane layer within both sides of the membrane. You don't have to place this in a very specific way. It can be, however you want to place this. It's very, very adaptable to what you're doing. But this is from placenta material. And so if you look at this, it has a number of properties here that are very beneficial to us. And so it is an immunoprivileged membrane. And so with that, we get an antibacterial, anti-inflammatory, and accelerated healing. And so showing a number of these cases, you're going to see even leaving this membrane exposed still works out very, very well. Okay? So we're going to reinvent the membrane rules here. So we're going to keep things very minimally invasive. We don't have to elevate these large flaps like we used to, maybe in socket grafting and things like that. We don't have to trim this membrane either. So this membrane actually folds on itself very easily. So when it adapts to whether it be heme or within type of a sterile liquid, it's very adaptable. It's very pliable. It's very, it's stiff at the beginning, but once you get this wet, it actually adapts very easily. So interproximal defects, things like that where you don't have to trim this membrane is very, very advantageous. Sinus perforations, things like that. You're going to see a number of these cases today. We don't have to fixate this membrane. We don't have to tack it. We don't have to suture this down. Like I said, it's very adaptable to our grafting sites. And it has an adhesion property, too, that I think is very advantageous, especially in perforations of sinuses and nerve repair. So I was a huge fan of David Letterman growing up. If you remember David Letterman, every night he would have a nightly top 10, a top 10 list. And so we're going to go through the BioXclude top 10, basically ways in which I use this membrane in my practice, okay? All the way from GBRs to even in hygiene, immediate implant placement, like I said, sinus perf repair, a number of these ways that we can see this. And so our first case here, this is actually a ridge augmentation site. We're looking at 24 and 25 region here. You can see very easily, especially on the CT scan, once you see this before, but these teeth need to come out. We're looking at replacing the 23 to 26 position with implants. And so we're going to do a ridge augmentation here. So local anesthesia, like any time else that you would do these. You can see on our CT scan, look at our teeth that need to be extracted. These are hopeless dentition here. And we need to not only get maybe a little height here, but also width of our bone, okay? So extraction of the teeth, very easy. Literally, these teeth are floating around in gingival tissue, held in by calculus. So these are the easiest extractions you'll ever have in your life. And so we're going to then try to set the stage here that we can actually place implants in the 23 to 26 position with a 4-unit fixed bridge here. But you'll fully appreciate on how this membrane works by seeing this done. I'm going to isolate our defect here, full thickness flap. I like to use, instead of a small round burr for cortical perforations, I actually use a laser here. Laser assisted corticotomies. This is a hard tissue laser from Biologics. So you can use these perforations. Look at the minimally invasive perforations within the bone and look at the bleeding that you get. So you don't have to have this big round burr to make these perforations. Very, very nice to atraumatically induce your surgical site. Periosteal release, very straightforward with any GBR technique. We've got a couple vertical incisions here. Utilizing sticky bone. This is PRF, platelet-rich fibrin sticky bone with a 50-50 cortical cancellous chip graft. Place this in our grafted site. And now you'll see the BioXclude membrane adapts very easily over this type of regimen here. And so what's nice about using sticky bone too is that it maintains space without having, big titanium mesh or titanium reinforced membranes or a stiff membrane. So you can adapt this in here, and then this is our BioXclude membrane. Look at this. So this is just dipped in sterile water and adapted over our surgical site. Place it right above, or right adjacent to the adjacent teeth here, hugging it right around that gingival margin. And so, like I said, it's very adaptable, very easy to manipulate. It's almost like cellophane. Once we get our barrier membrane here with our BioXclude, we'll then get primary closure and then come back in 6 months and then place our implants. And so traditional GBR here, so guided bone regeneration. Very nicely done. So again, primary closure. I use a 5-0 polypropylene for all my coronal suturing. You can see the sutures are placed right at the mucogingival junction. And then a resorbable suture. These are 6-0 glycolon on our vertical incisions. And so after 6 months, we get nice height and nice width. We have not seen the completion of this case yet. How about we go into an ailing implant? We see a lot of these in practice. If we look at over the last 4 or 5 years in my practice, I've seen like 350 actual patients, not sites, of ailing implants referred to my practice. And so, a circumstance like this where we have an ailed implant, we have, bone loss, to the second or third thread. Typically, if I have less than 50% bone loss around an implant, I'll try to save it. I'm even more, apt to try to save an implant if it's my own, rather than taking it out and starting from scratch. When I look at these type of defects, and you can see these circumferential defects around implants, it reminds me of this video I took in Rome. And so this is at the Vatican. This is the Bramante staircase. It's in one of the Vatican museums. And typically, when I try to explain this, especially to patients, is that bacteria I see that kind of sits on this thread and just works its way down the implant. Now, I'm not paralleling or, describing bacteria as the Italians here, but, the Italians are working their way down. They're not bacteria, but it does make this nice situation to explain to patients on maybe how these defects occur. So we're going to draw blood from the patient. We're going to then, utilize our centrifuge to make PRF. Like I said, I use a lot of sticky bone in my practice. So this is PRF sticky bone, 50-50 cortical cancellous chips. And we pack that around our defected area. Now, debriding this implant, we use a kind of a threefold way of doing that. Chemical, either like a tetracycline or an EDTA, liquid, light. We use laser therapy in my practice. And then we'll also use mechanical, which is an air abrasion. So adding all three of those together, that way we can maybe clean the implant surface somewhat to the ability to be able to graft these. So our graft is placed. You can now appreciate our membrane here. You can see our nice smiley face on the BioXclude membrane. And it adapts over the facial here. We'll also place another membrane on the lingual surface. And we'll get closure over our site. Again, 5-0 polypropylene suture. These are non-resorbable sutures. We'll have to take these out for the patient. And this is what it looks like at 1 year. And so, and you can further appreciate even on the x-ray here on what we're looking at with our bone growth here at 1 year. And so, complete regeneration with a nice adaptable membrane in a ailing implant situation. All right, how about a perforated lateral window? This is a patient, this is Dean. Dean comes in, all on X. We do a lot of all on X in my practice. And with Dean, we're looking at very pneumatized sinuses. We are going to place 4 implants, but we also want to graft the sinuses to come back in and put 2 posterior implants in the 3 and 14 position to get an all on 6. And so with that, we do the all on X, and we're also going to do a sinus augmentation at the same time. And so with that, you can see our sinus perforation. Sinus perforations, there's some clinicians that will try to suture this. There will be some clinicians that will try to maybe fold the Schneiderian membrane on itself. In our case, we'll actually use our BioXclude membrane. We put it in here dry, and that BioXclude membrane literally adheres to the sinus membrane. Very, very nice adaptability. We can then place our graft. This is our grafted site at the time of surgery. Okay. And then this is our implant placement 6 months down the road. All on 6, Dean comes back, a very happy individual with new teeth. And with further support, all on 4, now we go to an all on 6, sinus augmentations, basically save the day by our BioXclude membrane with our perforation. How about our localized sinus graft? We do a lot of these too. We'll go in here with a osteotome or reverse cutting drills, and we can use a 12 by 12 BioXclude membrane with a perforation like this. We can place that in there. Again, you place it in here dry, okay? It adapts to that site very, very well. We can then proceed again to go ahead with our grafting procedure and end up with a situation like this where we now have a localized sinus graft with our implant placement and continue to further along our patient with what they're doing. Okay, guided tissue regeneration. This is probably one of the best ways that I see the BioXclude membrane utilized, is that we see defects like this all the time, okay, to where we want to get in here, we want to clean this out very well, and try to regenerate the bone that's been missing here. And so in our site, typically what we'll see here, we'll probe this, and we get a 12 millimeter probe pretty much down into the base of the defect. So we know that because there's no mobility of the tooth, there's no fracture in the tooth, we want to try to regenerate this. So we'll clean this out really well, again, utilizing laser therapy, debridement, anything we can do to get in here, even a round burr or any type of situation where we can clean this out very well. And we place our bone graft, okay, in our defective site. You can see this on the lingual side as well. We can adapt our membrane here. So now this does not have to be trimmed, so which is great. You take a 15 by 20 membrane, you put it in, your sterile water or saline. You can then fold it on itself, push it through the embrasure space, pull it all the way around to the lingual, and then now we have a nice area where we get primary stability of the membrane really well over our graft, and then we get closure over our tissue. Like so. And so if you look here over time, regeneration, happens fairly predictably, especially in GTR, guided tissue regeneration. That's probably one of the more frustrated things that I saw in my practice, is that sometimes it would work, sometimes it wouldn't. And so in a lot of it too is the barrier membrane, I don't think was easy to manipulate like it was now. And so utilizing our BioXclude membrane, you can see here, this is where we started. This is at 3 months. And then a 1 year follow-up. complete regeneration of our bone here. Okay. That's a good question. So the question was, do I still use PRF sticky bone in a case like this? I don't, because this is a well-isolated defect, right? It's a four-wall defect. So the sticky bone, I mean, it probably has a little bit of an advantage of having, the patient's own growth factors within that graft, but I think it's, not something that you need. Yeah. Yeah. So it's a 50/50 cortical cancellous, Mineros graft. Yeah. Question. Absolutely.
And the graft is then between the graft. The membrane is between the root surface and the graft.
Correct. Yep, absolutely. This adapts perfectly to the teeth and to the bone all the way around it. So it has perfect, barrier around the graft. Yeah, absolutely. How about a case like this? So this patient was actually referred to me by one of my referring doctors. The tooth was extracted. The general dentist then placed a bone graft. The defect was, obviously into the inferior alveolar nerve canal. The graft was placed, pushed into the nerve here, and the patient then comes back and obviously has paresthesia of the lip and the chin. Okay, so at 3 months, the general dentist says, "I just don't think this is working out very well. Do you mind if you take a look at this?" So the patient still has numbness of this area. I said, absolutely, send it over. We take a CT scan, and you can absolutely see the graft that's actually pushed into the nerve here. Okay. So what we do, and after I read this article by Dan Holtzclaw, that utilizing the BioXclude membrane, we can actually use this as a nerve wrap. Okay. So we isolate the nerve, which is here, and we place our barrier membrane underneath this. Now I'm using Sinus lift curettes to try to get up underneath this nerve, being very, very careful not to tear it. But you can see the damage that was done ahead of time by the previous treatment. And so getting in here, isolating the nerve, getting rid of the graft, placing our membrane here, which you can see even better. And now we can then wrap this BioXclude membrane over the nerve and then use some type of a collagen plug or something, to maybe put over the top of it. You're not going to graft over the top of this. And so we leave this somewhat exposed, but this is what the nerve looks like when it's wrapped up. Nice little blanket. And this is what it looks like at 18-month follow-up. So now after about 4 months, the patient started getting feeling back to the chin and to the lip. At 18 months, complete resolution of the numbness. And so this is an area that's all healed in, nerves all intact, and everything is all back to normal for the patient. Very, very nice case to utilize. If you're doing nerve repositioning, things like that, these are great areas to utilize this nerve in those type of cases too. Question?
Did you ever put bone in there?
No, we never did bone. Never did bone.
So after 18 months?
That healed in on its own. Yep, correct. The only thing we placed in there was a collagen plug just to fill in the areas, just so that we got a little bit of hemostasis and not an open wound. So. Free gingival grafts, as a periodontist, I do a lot of these grafts, especially in the 24-25 area. And so, you can appreciate the mucogingival junction here. We've got mucosal tissue. Obviously, this area needs to be augmented. Patients in ortho getting ready to be done here. Whether we do these ahead of ortho or post-ortho, it doesn't really matter to me. We'll do them even during that time. And so with that, we're going to, like I said, go through our normal protocol here. This is our recipient bed. This is a split thickness flap. You can see the tooth here of where we're missing a little bit of the facial bone. We're going to clean these teeth really, really well. This is where our graft is going to go here. Try to get as much root coverage as possible. Utilizing 5-0 polypropylene suture for periosteal securing sutures. 6-0 securing sutures for a single sling, and then also simple interrupted glycolon sutures here. Try to get as much stability of this graft as possible. But utilizing, the free gingival graft, the number one complaint that we get from all of my patients and the majority of my patients is that the palate is completely terrible, right? If anybody has done a graft and they have a patient come back after a week and say, hey, how was that week while things are healing up? The bottom feels great. I don't have any problems here. The roof of my mouth is absolutely killing me, right? I've had babies, and it's easier having babies than it is having a free gingival graft. I get that a lot. And so I don't want to be compared to the gynecologist that is delivering babies, and the periodontist is worse, okay? And so we have nice stability of our graft here, and you can further appreciate of the type of thick biotype that we've added here, and the phenotype that we're going to change is to try to get nice keratinized tissue around this area. What's great about these grafts is they are like 98% successful. The free gingival grafts, autogenous grafts, are so resilient that you can have, I had a patient over the summer, last summer, that was a big water skier, wakeboarder kid, 17 years old, literally had a free gingival graft, went out the next day, major fall on a wakeboard, water basically went through his mouth and just kind of blew everything up, sutures got popped everywhere, just, it was kind of a mess on the next day, and the graft still worked. Like, that's amazing to me, that would happen. And so, again, you can further appreciate, the periosteo securing sutures here. We want to try to get as much stability of this graft as possible. But utilizing the BioXclude membrane now as a palatal donor site Band-Aid is that we can see here, now this is a big open wound. This is a very sore area. And so utilizing our BioXclude, we can use cyanoacrylate or any type of periacryl, to hold this down. You can also suture this down if you like too. What's nice about the BioXclude membrane too is that by putting it dry directly on the wounded site, even the heme there will actually adhere the membrane to the site. But I like to use a little bit of a periacryl around the outside. Nice, lost my connection here. Let's see. All right. Okay, so like I said, utilizing periacryl to fasten this onto the tissue. This is what it looks like at 24 hours. Nice hemostasis. It's nice for the patient too because it's covering the wound. And so this is at 4 days. The graft or the membrane has sloughed here. Got nice, angiogenesis into our site. And this is what it looks like at 17 days. So, very, very enhanced growth here on the palatal tissue. Normally, to have it look like this is about 28 to 30 days down the road. And so if you almost double in terms of speeding up the process here, you cut the healing in half. So, very, very nice done for the patient, okay? And this is what our graft looks like at 4 weeks. You can see here our mucogingival junction now is very established. This graft will last the patient a lifetime. So if you do not do free gingival grafts in your practice, this is one of the easiest procedures that you can do. That's probably the most beneficial that I see for my patients. Absolutely amazing. Whether it be around implants, whether it be around natural teeth, whether it be around multi-unit abutments in all-on-X's, the free gingival graft goes a very long way, okay? So where we started to where we are today, okay? Nice, thick phenotype. All right, how about congenitally missing lateral incisors? We see a lot of these where we need to build up not only, augment these areas, especially in the facial aspect. You can appreciate our defected area here. These teeth have been missing forever, so these are almost like bowl-like shaped defects. And so to utilize, again, PRF sticky bone in our BioXclude membrane, we can augment these very, very well. The height of the bone is fantastic. We just need to build out bulk. And so we're going to augment these laterally, again, utilizing laser-assisted corticotomies. This is a BioLace laser, erbium YSGG laser. And we perform these corticotomies. You can see here, nice corticotomies, atraumatic. I think that they do a fantastic job. Further studies are going to be noted, utilizing this type of a treatment and seeing what we can get with that laser-assisted corticotomies versus the burr-like corticotomies. Sticky bone, appreciate, how we can bring this in one kind of big chunk, almost like a block graft. Place our defected area with our graft, 50/50 cortical cancellous chips, and we are going to utilize our BioXclude membrane to go over the top of this. You can see how this very easily adapts over the top of our graft, hugs the teeth on each side. We tuck that into the palatal flap, and then we're going to get primary closure over the whole thing. Nice smiley face here. It's very, very cute. And so we'll get this all covered up. Nice barrier, bringing in growth factors to the site, utilizing the patient's own growth factors as well, and getting augmented bone very, very predictably. And so primary closure, we're getting a nice periosteal release here. You can see and appreciate really, the closure that we can get over the top of our graft. This is a 5-0 polypropylene suture, very similar to what you've seen pretty much on every case. And so going through, we do both sites. We're going to come back in at 6 months and then place our implants. Even better appreciated is looking at our CT scan. You can see here, this is all brand new bone. Look at this. We got about 7 or 8 millimeters of growth now in our defected area. So replacing implants in the congenitally missing lateral incisor position, making sure the bone is there first before we go ahead and place our implants. Again, you can appreciate what we have here with our growth, okay? And this is what it looks like at 6 months after things are healed up. We'll then go in, place our implants, and we'll be in good shape, okay? You can see our defected area is all filled in, looking really good, ready to go on to the next step with our implant placement, okay? How about in an extraction site, an immediate extraction site? I don't like to elevate flaps in these cases. So if we can extract a tooth, try to do it, we say atraumatically. Extracting a tooth is traumatic for anybody. But we use this dual zone technique. It's described a lot by the Salama brothers and Howie Gluckman out of South Africa. Well, we extract the tooth. We're going to try to keep the papilla intact. We make sure that we have a buccal plate, make sure that we have basically 4 walls of bone here. We're going to place our implant immediately. And so again, appreciate, what we're trying to do is maintaining the soft tissue architecture. We want to make sure that when we take a tooth out and we replace it with an implant, it's exactly, or if not better, than what it was initially. And so by doing these immediately, we then place our implant. This is a BioHorizons Tapered Pro implant. Place it into our extraction socket. We are then going to graft. Anytime that there is a gap, I know that we look at studies, anything less than 2 millimeters will fill on its own. I don't take that chance. I like to use small particle bone. We'll pack it into any type of defected area that we can. Bone is cheap. We can get that off the shelf. It's easy. And we're going to then not only place the bone all the way around our implant here, but we're also going to carry it over the top and even put it into the soft tissue. Dual zone technique, okay? Bringing it into a dual zone, not only bone, but also into the soft tissue. And so we can pack that up very high over the top of our implant, and then utilizing a barrier membrane here that we don't have to elevate a flap. So utilizing BioXclude, we can put it over the top here. You can see it's a 15 by 15 membrane, kind of folds over itself, and then we're going to then suture over the top of this, okay, just like so. And so we can use this and utilize it and use it exposed. So it handles very well. The soft tissue adaptability is great. It maintains our bone. This is at 1 week. And you see the granulation tissue now that's induced by that membrane, I think is absolutely superior than like a collagen plug or any type of other barrier membrane that you may use. Okay? Nice induction of soft tissue here. This is at 3 months. We're going to then go in and do an uncovery. Uncover this for our general dentist, who will then, we started here, and this is the architecture of our soft tissue now. Lost a little bit on the distal. Anytime we take a tooth out, we will get maybe a little bit of collapse and response from that. But maintaining soft tissue architecture over time, I think is very well done. Okay? Uncovery, simple uncovery procedure. You can utilize a tissue punch or a blade. If you have enough keratinized tissue here, you can do that. If you want to roll this, forward and utilize some of that keratinized tissue to further enhance the thickness here, you sure can. And in our case, this is our restoration. Nice architecture of our soft tissue, and maintain immediate implant placement atraumatically, basically making it as simple as possible for the patient and for your referring doc. Non-surgical periodontal therapy, real quick. This was a study done by Dr. Dodge and Rademacher out of Colorado. They looked at periodontal sites, with pockets that were in the 5, 6, 7 millimeter. We have those in our maintenance programs all the time, right? Patients come in, 6 millimeter pocket, hasn't resoluted itself. They're obviously probably going to get worse. So what they did is they did scaling and root planing and also placed the BioXclude membrane within the site, and they saw a resolution of millimeters, 2.5 to 3 millimeters, so going from a 7 to a 4 or 3. That's another application that we can maybe utilize our BioXclude membrane for even in our maintenance patients. Okay. How about an extraction with a facial plate that's maybe dehisced? These are a little bit more aggressive in terms of placing implants immediately, but this is a tooth number 7 that needs to come out. We then remove the tooth. The tooth has a fracture in it, which you can see. We try to remove that tooth as easy as possible. By doing so, there is no facial plate here. Because of the infection that was associated with this hopeless tooth, is we can use a periodontal probe, and you can see here that we have no facial plate on this site. And so obviously at this point we need to explore this area. We're going to then do a full thickness flap and see exactly what we're dealing with, and this is where the tooth used to be. And we're going to degranulate this, try to clean this up as best as possible, get rid of any infection. And now we can either graft this and come back and place an implant at that point, or can we place an implant now? And so immediate implants I try to do all the time. And so we've got great peaks of bone here on the adjacent teeth. The implant, again, is prepared. The osteotomies are prepared. And we are going to then place our implant. What's nice about, this type of picture, you can further appreciate of where the implant is going to come out the cingulum of the tooth. We're going to try to make this as easy as possible for my general dentist to restore with a screw-retained crown. And then we have an architecture here of bone that I think that even by placing our implant, we can grow facially very easily utilizing the bone grafting materials and also the membranes that we have at our disposal. And so you can see then appreciate of where our implant's going to go. Implant is placed within our socket. You can see here we place it deep enough where we get a nice emergence profile for our general dentist, make it really easy for them to restore. It's coming out the cingulum of the tooth, but we have now got to graft all this. And so again, utilizing our grafting materials of choice, 50/50 cortical cancellous chips, utilizing our BioXclude membrane over the top of this, just like so. You can see the adaptability of it all the way through, adjacent to the teeth, all the way around our graft, kind of folds right over the top of this. And we then get primary closure, polypropylene suture, suturing directly at the mucogingival junction, not in mucosa. And then our vertical incisions will be done with either vicryl or monocryl suture like Glycolon. And so we'll come back, and then another thing too that you can appreciate here is that we have a little bit of the exposure here on the coronal aspect where the membrane is actually exposed. And so this is where the tooth used to be. So the membrane is all in here, all the way out to the facial, but we have a little bit that is exposed here. Not a problem. We can leave that exposed with our grafting material. Okay, you're going to see this is going to heal pretty uneventfully. And so this is at 2 weeks, and look at the soft tissue already forming within that site. And so this is at 6 months, nice peaks of soft tissue. We can then take this, uncover it, utilizing provisionals or custom healing abutments to start now mitigating some type of a emergence profile out of the soft tissue that's going to look natural. And so patient comes back, we get this restored. I don't have a follow-up picture, but this is a 2-year follow-up that the general dentist actually sent me yesterday. And so nice bone growth here. We will take a CT scan. I'll get a better follow-up to see what that facial bone looks like, but really no issues with this patient. Nice restoration. Okay. So, we talked a number of cases here. I know that my time's run out already. But utilizing this membrane is very versatile. It goes a long way. We can leave it exposed. It's easy to adapt to our grafting materials. We can utilize it in traumatic situations like even nerve repair. If you look at, some of the things that we've done even through Instagram. Instagram has been a absolute amazing portion of my career. And so some of my best friends that I have to this day have actually met on Instagram. For some reason, we both swiped right. And so John Kim and Sean in the back and Dr. Martin in the back, a lot of us have met through social media. And so, in fact, Martin and I, we met a long time even before that, before even social media was a thing. But we teach a lot. You know, we learn a lot from each other. It's a community that where you can be vulnerable and you can post cases, you can get feedback. You know, Robert Stanley's in here too. You know, I've learned a lot from him through social media. Just a lot of people with a lot of education that we can meet through such a simple platform like Instagram. It's amazing. And so we also host Brad Ross, who's a periodontist out of Miami. We host a show called the Perio Bros Show. So we get on and we talk about cases and have a lot of fun with that. So get on here, follow me. Definitely, I would love to meet each individual in person. But if we have to do it virtually, we can do that too. This is my information. If you ever need anything, I answer emails a lot. You know, I teach a lot with David Wong. He's a periodontist out of Tulsa. And if you go to his inbox on his email, it's like 11,000 emails or something. It's something crazy. It's 5 or 6 digits on his phone. I didn't even know that you can do that. If I have like 5 or 6 unopened emails, it drives me crazy. So if you email me, I'll get back to you. I promise I'll do it within like 24 hours. If you have cases that you have questions on, or even questions about the membrane or anything in practice, I would absolutely love to talk to you about it. Again, Red Rock Institute is our institute. Formed that in 2018. We host a number of courses. There's a photography course that's absolutely amazing that we host in October. A number of soft tissue, hard tissue grafting courses. If you're interested, please just look at the Red Rock Institute. You can go to redrockinstitute.com as well. And it's been a pleasure. Thanks for putting up with the AV stuff. I know it's frustrating, but I appreciate you. Thank you very much.